Good morning, Your Excellency Abdullah bin Khalid Al-Qahtani, Dean Sheikh, Doctors Araisi and Krohn, and distinguished guests and attendees. Certainly for me, it's a great honor to open this meeting and to frame up many of the very important issues to discuss today about global health and medical education and how you bring innovation to the table. We live in a very, very exciting, globalized, and rapidly changing world. We live in a time where there's great breakthroughs in science and technology, a time by which we think about so many ways to bring innovation to a table. And yet, we also live in a time of great challenge. Non-communicable chronic disease, such as diabetes, obesity, is on the rise. We know, of course, here in Qatar, it's a significant problem. We live in a time where there's aging population, where the number of patients or people over 65 with chronic disease is going to be on the rise. And we still see a huge global health disparities or inequity in the United States and elsewhere. Certainly recently with MERS and Ebola, we recognize the importance of such a globalized world with emerging infections and re-emerging infections. So there's no question there's an increasing demand for healthcare and health, while we have more tools, and the question is, how are we going to use them to increase collaboration? I think it's fairly clear to all of us that healthcare systems must change. We have to shift from a disease-centered approach to health and wellness, as you heard earlier, happening in this country, to treat organs to whole patients and whole person, to go from high-tech technology but also to high-touch and promote health behaviors, to go from hospital-based to community-based, personalized and precision medicine, patient-centered, and democratized the ability of patients to use their own information and to be consumers. In this context, healthcare workforce is the driving force for success if we were to realize this vision. And healthcare workforce, of course, emanates from our educational system. Healthcare workforce should meet healthcare needs in the terms of capacity and also competence. Now, the LANCET Commission, the work published in 2010, looks carefully at where we are in global education. Health Professionals for a New Century is called, and one of the commissioner, Dr. Kerr Young, is here with us today. What they pointed out is that there's this tremendous insufficiency in capacity and a tremendous difficulty in distribution between disease burden and healthcare providers. As you can see in this slide, the heavy blue shows you where the heavy populations are, going towards a lighter blue. And then you look at B, which is the burden of disease, concentrated in Africa, Asia, and South America. But if you look at the number of medical schools, there's a big disconnect in this distribution, and important if you look at workforce. So you can see the distribution is extremely poor. Also, it's estimated that we have a shortage of 2.5 million healthcare workers, and this number is just going to go up globally over time. If you look at the distribution of the population in terms of urban and rural on this particular WHO study, you can see that the distribution of nurses, physicians, are mismatched with the distribution of where the populations are. So therefore, we have much to do, and we also see big gaps in skills and competencies. The current health professional education teaches disease-centered care, emphasizes acute in-hospital care, is fragmented, does not necessarily promote teamwork, is episodic rather than continuous care, and provides insufficient understanding of community health, little training in the use of information system, and a mismatch of competencies to patient and population needs. So it's fairly clear to all of us that health professions need new skills and new competencies. Skills in understanding social and economic health determinants, more skills in primary care and public health, the use of technologies, the ability to collect data, analyze, the understanding of policy systems and regulations, leadership management, and interprofessional collaborative skills. The LANCET Commission asked for a reform, a global health education reform, needed a 21st century. As you can see, in the 19th century, it was more instructional by institution. And then, of course, over time, we have introduced science-based curriculum, usually based in universities. I would say the last decade, we've shifted much to problem-based learning in academic centers, but we must go towards system-based learning, giving competency in local and global issues, using health and education system integration. So when you think about learning, there are multiple levels of learning. There's information, you become expert in your area, to formation, that is social and values, become professionals, to transformation, that is leadership attributes that can really change the way education and healthcare is delivered. In that context, as I said this morning to His Excellency, that education system and health system must be aligned, if not integrated, because education system should provide the health professionals to meet the goals of the health system, and health system need to provide the opportunity for education to enhance their educational experience. At the Institute of Medicine, we have done many work in this area, one of which is the Global Forum on Innovation Health Profession Education. We have 62 members, 18 different professions, 8 different countries, 45 sponsors. As you can see in the bottom, we produce many reports and ideas of what we must do to move the agenda forward. So we believe that health professions education should address both capacity and competency to develop a right-skilled and efficient workforce, to enhance interprofessional practice, to connect with the community, to build leadership, and also to build IT and information competency. Let me quickly talk about each one of this area. In this issue of right-skilled and efficient workforce, it's really important that health professions being able to practice at the maximum potential. In other words, if more than one person has been trained to perform the same task, we must avoid redundancy, and we must, in fact, the task not to be given the overly trained individual, but to the next level, whereby providers can practice at the top profession. This task shifting can allow efficiency and integration of care. We published a report in the Institute of Medicine this summer called Graduate Medical Education, Why It Needs Reform in the United States. But as you can see here, simply increasing the number of physicians is not likely to resolve this issue. We have to think about utilization of other workforce. Of course, nursing is a critical part of our profession, health profession. In our report on the future of nursing, published 5 years ago, it has 250,000 downloads and have transformed nursing practice in the United States. Nurses should be leaders. Nursing should be practicing the top profession. 10% of nurses, in fact, should go on to a high baccalaureate degree, because the data shows the higher the education, the better is the patient outcome. We have to also think about educating other workers, social workers, pharmacy, but also community health workers. As you can see, this model, LANCET China, they train volunteers and professionals to provide chronic disease management, education, intervention, physical therapy for a fixed yearly membership. So educating the whole spectrum in order to provide an efficient workforce. But to do so, we also need inter- and trans-professional practice. As you can see in the top of this slide, the common pre-secondary education is to train doctor, medicine, nursing, public health separately. And then when they come to work at the bedside, They learn teamwork. I think where we need to go is to actually train them with competency at the time of post-secondary education. Systems teamwork, so that when they come to patient care, they already have the knowledge of teamwork. And of course, importantly, is trans-professional education, to bring in other community health workers and, as I said, other workers into this whole system network to care for the patient. In this context, the IOM report on establishing transdisciplinary professionalism, I think is extremely important to call for new professionalism whereby you create and carry a shared social contract, not only, as you can see in the so-called medical profession, but also contract with society, a new unified professional ethics to talk about needs of society and to meet the needs of society, not only in the issue of medical care alone. Finally, it must connect with community, and of course, it's relevant community. In Philippines, they noted this medical school that 60% of the graduates leave the country, and so they redid their education in community, where students are recruited from under-resourced communities, nominate the scholars. They're required to have a service leave in the home community, and the competencies are based on local needs. And that's one way you can look at how it's connected community. Also, it's important to think about leadership development. Certainly, I'm a strong believer of the need to train physicians and providers as leaders of real-world experience so that they can lead and be the change agents. In this context, there are 4 themes that one must train in leadership across healthcare: leadership, skills, management, innovation, and now quantitative health sciences. So the long-term goal is to contribute, develop a workforce of the future, where new roles across clinical and non-clinical care to enable task shifting, care teams, and coordination. At Duke, I created a training curriculum whereby we looked at starting with high school students, creating actually a unique, what we call magnet school, where students begin to learn about science, not only STEM, but health professions, to undergraduate and medical school leadership, to leadership and resident fellowship, all the way to faculty, continual improvement in training leadership. As you can see in this slide, the competencies that they learn include strategy, healthcare ethics, leadership, finance, decision-making, IT, and so on and so forth. Now, in that context, we were particularly proud of the fact that we created a residency pathway so that residents who have interest with a background with MD and possibly MBA can begin to do projects during the residency to become leaders of the future. I also created a leadership program for young faculty, a mid-career, so that they actually can amplify their capabilities to become leaders. Importantly is the need to know how to use information. And we created a Master of Management in Clinical Informatics with our business school, and also introduced the whole concept of learning health system proposed by IOM, where our graduate medical trainees have 3 levels of learning. Learning how to use electronic health record, but also access information data, to learning how to do projects at the 2nd level, to a 3rd level that actually function at a much higher level of being able to lead research and obtain a master's degree. So I think that if you pull these together, you recognize there are many principles which applies globally everywhere of where we need to take health profession educations. But it's important to emphasize education has to meet unique local needs, where you can think this high level, how does it work on the ground? And countries are different. If you look at this slide, you can look at economy or the World Health Organization health systems ranking, infant mortality. You can see that they differ from country to country. And consequently, one cannot simply say, this is the way US education should influence, education in Africa. We have to work together to learn how we can actually take the high principles and apply it locally. In this context, just look at Singapore and Tanzania, the tremendous differences in the disease burden. You can't see the slide very well, but it emphasizes the difference in Singapore of ischemic heart disease, whereas in Tanzania, of course, it's HIV and other infectious diseases. So I think different regions and countries have different needs. So the rest of my conversation, I'm going to simply say, let me divide them into the following category. Low-income countries with developing health systems like Tanzania, Rwanda as two examples. Upper middle countries, income countries with developing health system like China. High-income countries which is still developing its health system like Qatar. High-income countries with a developed health system in Singapore. And of course, high-income countries with high-cost health system like the United States. In low-income countries, the needs are often more health workers, physical infrastructure, accreditation system, and retention of faculty and graduates. For example, in Tanzania, Duke has been in Tanzania for almost 30 years, and over the years has helped the Kilimanjaro Christian Medical Center develop an academic medical center with infrastructure, research capability, administrative regulatory capacity. And it's only by bringing these things in there can you elevate, in fact, the quality of education and care. In Rwanda, as a part of Rwanda health profession agenda by the country Rwanda, working with, in fact, US, funded by US government, the money for AIDS and malaria, tuberculosis, and also Clinton initiative, they brought in 23 different medical school, nursing school, etc., to participate in graduate medical health education. Duke participated in this by each committing 7 full-time faculty members from nursing school, medical school, and Global Health Institute to be there to work alongside with them in giving graduate medical education. So this is another way of looking at how you develop this. In China, you can hear from Professor Ke Yang many of the issues that they face in terms of looking at how to move the narrowly focused curriculum, rigid pedagogical methods, and training confined to hospitals to moving towards a reform which is undertaken in 1998 with her leadership and many others to increase the number of students, targeting 300,000 general practitioners by 2020, but importantly to create a 3+5 education system, that she'll tell you about, and also incentives for rural practice. In high-income economies such as Singapore, their need is to bring a knowledge-based economy in, to create more research, more cutting-edge development. In this kind of context, we've been very lucky with Bob Kamei's leadership here that Duke has been part of the creation of Duke NUS, very similar to what happened here at Weill Cornell, in which we have now successfully not only created a successful medical school, but also integrated with the Sing Health system and the academic health system, in which the students can move seamlessly between the school and also into the bedside for teaching. And I emphasize that to be extremely important. And finally, of course, very impressive work done in Qatar, where under His Excellency's leadership is a health system that's being developed and a health strategy for the nation. But Qatar needs stronger local capacity. My understanding is if you look at 8,000 nurses, only 300 are Qataris. And in fact, if you look at the number of workers and physicians, many are expats. And so the important is to create a workforce that's sustainable, that's committed to here, that transcends silos. And of course, in so doing, they have done a really impressive work, as you heard from Dean Sheikh, the bringing of Cornell Medical College in Qatar, the creation of an academic health system with Hamid Qatar and the others. And I'm very, very pleased to be on his external board. The Interprofessional Council, the creation of a national research fund for grants to developing interprofessional competency, and the new medical school of Qatar University College of Medicine in order to meet the capacity needs. These are very forward-looking activity, and I wish you lots of success in moving your agenda forward. The United States will recognize what we need to is lower the cost of care, remove the health inequality, more personalized medicine, more patient-focused, high quality and outcomes, and better balance between specialty and primary care. And Institute of Medicine have been very much involved, as you heard, in a number of studies and reports on behalf of the government and independently to advise how to begin to make changes. I believe what we need is reform GME. We have to enhance nursing and provider education, as we did in the nursing report, into professional education, leadership development, and emphasize in primary care. We need new financing models and increased opportunity for innovation. So I'd like to end my talk by saying innovation at the end of the day will be the tool we're going to use to drive success. When we look at all the principles that we all want to aspire to and the local needs, you have to bring innovation to say, how do you address those needs? And of course, innovation can be seen in many different levels, from an organizational structure level, from a financing structure model, to innovation in curriculum, in teaching methods, in leadership development, in recruitment methods, and many others. And of course, you already heard the earlier conversation that in fact, you can bring in new innovative teaching methods, such as we did in Duke and US 10 years ago under leadership of Bob Kamei, called Flipped Classroom, or Duke Leader Program. And now this is being used widely as a way for people to learn first at home and then come in to learn at the classroom. To use of simulation, as you're now developing here, to self-driven learning, and of course, moving forward, democratization of education through massive online courses. How these will all fit in is part of a conversation, I believe, this meeting, and of course, ongoing conversation in future. But we also need to understand that we need to train our trainees to be innovative, not just give them the tools, but they have to be the leaders of innovation. Certainly for me, I've been very fortunate at Duke to create a GME Innovation Fund that's been very successful, and also an Institute for Health Innovation, which hosts workshops, boot camps, design training, and others to engage everybody, particularly trainees, to drive the change through innovation. So in summary, global health profession reform must be enabled, and it takes the mobilization of leadership, such as you have in this country under His Excellency and Dean Sheikh and others, to put in a lot more investment into education than we have done today, to align accreditation with the training and to strengthen global learning. I'd like to conclude to say the world is in need of a global health education reform. This reform should be globally informed but locally specific. And moving forward, let's train health professionals who can connect with patients, identify problems, and imagine new solutions through innovation, and lead us towards a bright future. The goal is to have a transformative and interdependent professional for equity in health globally. Thank you very much.